Good evening, welcome everyone. Thank you for joining us tonight for our monthly Mastery Webinar series. Tonight will be all about x-rays, mastering fluoroscopy. So we'll have really great discussions tonight surrounding the importance of fluoroscopy in these Lapiplasty cases and the importance of it in mastering these cases. Our faculty, which I'll talk about in a second, will talk about, getting these preoperative x-rays, making these assessments, some efficient OR setup for absolute efficiency in the OR, best practices in capturing the ideal intraoperative views, and a whole lot more. If you are new to our GoToWebinar series, all attendees are automatically placed on mute upon joining. However, we really encourage these to be interactive. So any questions or comments, please feel free to type those into the questions section at the panel on the right of your screen. We'll be monitoring those and asking them throughout. And if there's any that we don't hit during, we'll have a little bit of time afterwards to hit on those questions. So without further ado, I'd like to introduce our esteemed faculty for this evening. If you'd like to advance the slide, Dr. Dayton. So we have Dr. Dag out of Decatur, Alabama, joining us, and Dr. Paul Dayton out of Ankeny, Iowa. Gentlemen, thank you so much for joining us. How are you?
Good to be here.
Yeah, it's great to be here. Well, it's great to be here in Iowa. I guess Justin's in a different state.
It's a little hotter down there, I think, Paul.
Yeah, it's been nice here. So yeah, it's going to be a fun discussion. So hopefully bring the questions so we can all kind of learn some new things together. All right, so here's the obligatory slide that keeps the lawyers in a position and a job. So obviously we're consultants, but as I say before all of these webinars or labs that we have, I mean, everything that I'm going to say is what I do and how I do it, and in many cases how I've done it for years and years. So I apologize to Lauren if I contradict something on a slide, but we'll say it the way it is as we see it. So all right, so we're gonna talk about a lot X-ray today, but I think when we talk about X-rays, we're really talking about understanding the three-dimensional nature of the procedure. So instead of our typical traditional osteotomies where we really only care about the AP X-ray, when we talk about what we're doing with Lapiplasty, which is a three-dimensional tarsal metatarsal realignment, it's really important to understand a lot of nuances on each X-ray view. So really that's the gist of it is, how do the X-rays kind of line up with what we understand as this three-dimensional deformity. So why don't you take this, Justin? We'll kind of walk through how we see preoperative assessment.
So for my new patients that come in, my MAs will identify if they're here for bunion and just make sure that they all get 4 views. So we're all used to, number one, standing. That's sort of a given. But we're all used to getting an AP, oblique, and the lateral view. Now, a lot of people don't do the sesamoid view, and I would strongly encourage you to do that view. It's insanely helpful. And so on all my bunion patients, they get all 4 of those views, and that helps us to really begin to see this thing three-dimensional. As you read a lot in the literature about sesamoid position, maybe it's subluxed, maybe it's not. You won't know that unless you get that sesamoid axial view.
Yeah, it's super important. I mean, I remember it's probably been over 15 years ago when we first started trying to understand, how everything's aligned in 3 dimensions with the bunion. As soon as we started looking at the axial X-ray, it just gave us an entirely new understanding of what a bunion really is. It's not just the metatarsal moving off the sesamoids, and this is a pretty good case to really show that. You can see that the sesamoid looks like it's in position 6 on the AP, but when you look at it relative to the metatarsal head on the axial, both sesamoids are still in contact with the metatarsal head, and the rotation kind of gives us this radiographic artifact. And once we saw this and we looked before and after, and that's the key. Once you see what that position is before and after, you really start getting a better feel and understanding for where things are positioned. And putting everything back to normal anatomy is what we're all about, and we have to not just artificially pull the sesamoids medial, we have to know that we're actually rotating things back into a normal position. So take us through kind of a lot of the cues that we use, Justin, when we look at these preoperative x-rays and decide on a procedure.
Yeah, and I will say, Paul, on the axial, when I started doing those, man, it was a game changer for me, because then I knew, like, hey, if these are subluxated, I probably am going to have to do a little more sesamoid work on there. But if they're in the groove, I'm going to have to dial in my rotation just perfect, because the sesamoids are already there. So it really does help from even in the OR standpoint of being prepared. And so if you don't do that yet, definitely think about it. Reach out to Treace here, and we can help with that setup. Now, as far as looking at really the AP view, there's lots of different things to consider. You've got the very large IM angles. We're all really used to seeing those, that sort of lateral sesamoid peeking out. We're really keen on looking for arthritic changes now as well. Because if they do have those early arthritic changes, then that would be somebody that can get pain at that MTP joint later. And so in my practice, I know when I start to see those early changes, I tend to talk to them more about doing an MTP fusion. And even on that axial sesamoid view, if those sesamoids are very arthritic, but the joint still doesn't, that's one I'd still consider doing a fusion on a lot of times. And so looking for that arthritic changes helps. Metatarsus adductus. I know a lot of you have heard about adductoplasty, and this has been a huge game changer as well, really being able to radiographically identify that and begin to treat those patients appropriately. And then just some of the other more oddball things, the obliquity of that TMT joint. You can have some of that little facet over there off the base of the first metatarsal. Knowing all of those things ahead of time does tend to help a good bit. And so definitely be critical of looking at your x-rays. Don't just say, hey, this is another bunion, I'm going to do the same thing.
Yeah, totally agree. So since we're going to be talking a lot, I think, about the difference in the x-ray cues that we see with a pronated versus a supinated x-ray, I just wanted to look and point out a couple of things on the x-rays that I see. Obviously, the metaductus, we have to recognize it. We can't ignore it anymore. We have to correct 2 and 3 if you can even hope to get the first ray back into normal anatomic alignment. So to me, that one, at least today, is very straightforward. As Justin said, arthritic changes of the MTP, I don't even mess with anything other than a 3-dimensional MTP arthrodesis. You can get amazing IM correction, and our MTP patients are some of the happiest patients we have. But when I look at these x-rays and we say we're looking at the diastasis on the left pane, and then the fourth one over is an oblique cuneiform. So both of those are a relatively pronated view, and it's interesting when you look at some of the artifacts that we see on an AP x-ray, whether the foot is supinated or pronated. These are really good examples. So that oblique cuneiform, if we were to supinate that foot, the angle would change dramatically, and we've published on this and others have published on that. And when you look at that apparent diastasis, Eustace published a really interesting paper, and they actually use that overlap of the lateral side of the cuneiform to assess the amount of frontal plane rotation. So, we need to understand a lot more than just one particular point. We have to understand that if I change that foot position from supinated to pronated, I'm going to change that appearance of diastasis. I'm going to change the appearance of the obliquity, and I'm absolutely going to change the appearance of the sesamoids, which is, again, a lot of what we're going to talk about tonight.
And even the elevatus on that AP X-ray, depending on, it can look shorter or longer, depending if they're cavus or more flat-footed.
Yep, absolutely. So obviously, I mean, we don't need to belabor this. We're all experienced foot and ankle surgeons. You know, we have to globally assess the foot. You know, if there's a hindfoot deformity, if there's gastrosoleal equinus, if there's, subluxation, peritalar subluxation, we have to recognize that and factor that into our decision making. But the one thing with the whole idea of three-plane correction is that the sagittal, and we don't talk about the sagittal plane a lot, but the sagittal plane is one of the three planes. It's one of the planes that we strive to correct completely. And so we get questions about this a lot. This patient has elevatus, can I still do a Lapiplasty? And I'm like, of course, that we're correcting the transverse plane, the IM, to the degree it needs to be corrected. We're correcting the frontal plane to the degree it needs to be corrected, and we're also correcting the sagittal plane. And the instrumentation is designed to be able to do that. So, if there's a true pathologic flat foot, I'm worried about it. I'm doing something for it. But if it's a non-pathologic, low arched foot, or even this high arched foot, I know I can get full three-plane correction with the system as long as I follow the steps. Where are you with that, Justin? Are you fixing every flat foot, or are you of the mind that you can get good first-rate correction even if there is a mild to moderate hindfoot deformity?
Well, I'm right there with you, Paul. So if they've never really had a lot of the flat foot complaints, they don't have the midfoot pain that's radiating at the posterior tib tendon, and they've had flat foot their whole life and they're used to it, I'm not advocating to change that whole position. I'm just addressing the bunion. And so I think that's a really good point, the pathologic versus non-pathologic flat foot. You got the 30-year-old that's had flat foot since they were a teenager. It's not really hurting them. It's just the bunion. I'm just doing the bunion.
Yeah. And then, the gastroc, my threshold to a gastroc and one of these flexible, what I call a non-pathologic flat foot, they don't have subtalar pain, they don't have talonavicular pain, posterior tibial tendon symptoms. My threshold is pretty low to doing a gastroc, and we've been actually following and measuring a lot of our patients with a three-plane TMT realignment and relieving the deforming force of the gastrosoleus equinus. It's pretty amazing. The foot overall globally gets better. And again, we're not, neither of us, I don't think, are talking about the the pathologic symptomatic flat foot, but just these mild deformities. I think you can get, I in literature would suggest and back me up on that. I think you can get good stability through the medial column, which actually helps the overall foot alignment and function.
I agree with that 100%.
All right, so do you really need axials? We don't even need to talk about this, right, Justin? You do. We do.
Right.
It can be hard. It's hard to train the X-ray techs to do this, but once you ride them hard enough for long enough, they get used to it. It gets easy. It's not as cumbersome. It's not as foreign, and it is so valuable to look at these different situations or iterations of what at least I consider to be a hallmark of frontal plane rotation, which is the sesamoid position.
And if you look at these, like that first one, that arthritic change, that's one that I'm pushing them for an MTP fusion. And I may even end up taking out that lateral sesamoid altogether. And that can really help me swing that IM angle back down and get that closed down, full 3D correction. Whereas the second one, I know I'm doing a lot of rotation work, and really the frontal plane rotation with subluxation, but not a lot of arthritic changes like this third one. I know I am going to have to work on those sesamoids a little bit even after I rotate my metatarsal head in. And so just knowing that ahead of time is very valuable knowledge. It helps you get a better outcome in surgery.
Yeah, 100%. Knowing whether it's pure rotation, and we've published a couple of papers that were pretty consistent that about 2/3 of Mindy's and my patients are rotated without subluxation, so they're the second pain. And that's a powerful piece of information because I know I'm not going to need to do any medial plication. I just need to concentrate on getting all three planes of my correction right. So I have to concentrate on rotation, as Justin said. I would say the third one for me looks pretty arthritic. When you see a sesamoid that's flattened out and has a nice little peak here that I'm pointing, a little spur off the side of it, that's a pretty arthritic joint. You can even see the cystic changes in the joint. So again, the first one is obvious, as we talked about, it is arthritic, but I get a lot of information from the Axial regarding sesamoidal metatarsal arthritis, because that is the kiss of death with realigning the first ray. If it's arthritis, those patients didn't have sesamoid pain, they had bunion pain, bump pain, or they had joint pain before the surgery. But after surgery, when you realign the sesamoids, if they're arthritic, they end up having a stiff joint and sesamoid pain, which is super frustrating. And the one last thing that I would say about the fourth X-ray over here is be careful about looking at a joint like this and saying there's no crista or it's eroded. This is probably a very young patient. And I will tell you, I have done many, many, many cases where it looks like this pre-op. I do my full three-dimensional correction post-op, and then magically the crista is back. And it's either due to dorsiflexion, plantar flexion, some kind of a radiographic artifact. So, if the joint's degenerative, yeah, the sesamoid or the crista can wear down, but there's a lot of cases where you may not see the crista, and you have to factor that in, especially if it's a young, healthy patient.
Hey docs, before we jump into kind of moving into intraoperative stuff, I know we're talking axials here. There was a question that came in asking, how often are you doing gastroc recessions?
It's not every time for us. It's often, and so our criteria is if with the knee extended and the foot supinated, they cannot get past 90 degrees. So dorsiflexed past 90 degrees, that's our threshold to consider gastrosoleus recession. Mindy and I published a paper looking at foot position relative to the measurement of ankle joint dorsiflexion, and we found that the most reliable position was a slightly supinated position of the foot, locking the joint so that we don't, we're not measuring foot motion, we're measuring only ankle motion. So that's what we do. I think it's maybe a lower threshold than some, but probably a much higher threshold than others. How about you, Justin?
For me, I'm probably a little bit less than you. I would say probably about a fourth or less of patients I'm doing it on. But I do talk to them, and I do ask them about their tightness, because I think that actually is important for post-op as well. And it's not a hard procedure to add in there. Not as much as the Seattle guys, but I'll say probably about a fourth.
Yeah. When if there is significant tightness, I mean, we know it definitely affects the overall foot function and position, and can affect your outcome for the same reason. So axials, we use this little super expensive piece of foam that you can buy. It really does help the X-ray techs get a good view. And we actually have some teaching slides if anybody's interested on, position of the tube and how to get the patient positioned. Obviously, like all of our foot views, we don't ever do 2 feet at the same time. We need the patient in angle and base of gait. Some literature would say that you want to try to simulate the beam at the same angle as the IM angle. That's super hard for the techs to get a handle on, but in a higher IM angle, obviously the first metatarsal is angled medially, so you're going to get a skewed view. So there's a lot of considerations, and we have some nice tips that we can pass along if you need them. It's actually not all that hard to get an axial, a good axial, in the operating room on the mini C-arm. We don't do it all the time now. We used to do it in every single case. Now we use a lot of the AP X-ray cues to understand what we're doing, but certainly doable. And if you have any questions at all about where your sesamoids are, very easy to get that view. You can see here with toe slightly dorsiflexed and then the foot plantar flexed, which is the key heel on the plate. You can get a pretty good view down the sesamoid metatarsal complex. Do you do axials very often, Justin, in the operating room?
I'm sort of like you. When I first started getting the axial sesamoid in the office, I did them all the time in the OR because I really wanted to see, am I getting the correction? Am I getting that rotation down? Now that I feel pretty comfortable that if my AP view, if those sesamoids look good, and it's a true AP view, which we'll talk about here in a minute. If it's a true AP view and those sesamoids are good, I tend not to be honest with you. But I will say for new people that haven't really done a lot of this, do it on every case first, because it is very helpful to see, am I getting that rotation that I need?
Yeah, I agree. And then you can correlate it, mentally, we correlate everything. So you can correlate what you're seeing on the AP with what is really truly happening on the axial. And there's always questions about, we're dorsiflexing the hallux, so is that really a true axial? Well, I don't know. We're stretching the soft tissues. We may be changing the relationships to some degree, but the key is if we're consistent with it. If I get my pre-op views the same way every time and my post-op views the same way every time, I'm able to look at each one of those and make a determination on how good my correction was or not. Now, again, the argument of dorsiflexing the hallux is certainly a valid one, but the whole idea is that's the best we can do. I don't unfortunately have the disposable income to get a weight-bearing CT yet. Love to have one, but this is the next best alternative, and if we're consistent with our views, I think it's very valuable information. So everybody knows, I think, or maybe not everybody knows, but Lapiplasty is not just a TMT arthrodesis. It's not just a 3-plane TMT arthrodesis. It's a completely different way to look at correcting a bunion. So obviously bunions come with arthritis, they come with metatarsus, they come with metatarsus and arthritis. And we don't really care about the angles. What we care about is the relationships. And so we have to identify those relationships preoperatively, and we have to correct each one of those relationships, whether it's arthritis or metatarsus or just a simple hallux abductovalgus. We have to identify and correct those. And so to me, this algorithm is literally the essence, the key of Lapiplasty, and it makes my life so easy. And we have it's not this group of pictures, but we have a poster that we made up that has each one of these categories with a pre and post, and we show the patients their x-rays, we show them this algorithm, and we say, this is where you are, and they look at that and they go, wow, you're right, I have that, and you need to correct that to get this back to normal. And this is so different than my old days, before 15 years ago in practice, where I basically was not even showing patients x-rays and just telling them, hey, you need this, and it's going to come back anyway, so it's no big deal. Now we're able to really hone in on the correction. I know, Justin, that you really have identified with this whole process. How do your patients, how do they respond when you have the discussion and show them these pictures?
Well, I'm in the South, so I came up with what I call the Bunion Bible. And so I have almost these identical x-rays, except they're my own. That way I can tell the patient, hey, this is a patient I did. But I have those in a little pamphlet booklet thing. And so I'll flip to it and say, look, here's the different ways we can use Lapiplasty to treat your bunion, whatever category that falls in. And then what I'll do is I'll star it on their paper. This is the one we're going to do for you. And like you said, it makes sense in their brain. Like, oh, wow. So yeah, you're going to take out that bad joint here, get it lined up and put plates and screws. Like, yes, exactly. And this is what it's going to look like afterwards. And so it really helps them, I think, mentally to say, okay, that's what the plates and screws look like. That's where they're going to go. I'm okay with that.
Yeah, 100%. And then when they see their post-op x-rays, they're like, dang, that looks just like what he showed me it was going to look like before. And that's exactly what I signed up for. So yeah, it's super powerful. And it really goes to the Lapiplasty philosophy that it's really different than this whole angular severity based thing that we were taught with IM angles and all the other things. It's all about anatomy. Where's the pathology and how do we put it back to normal? So a lot of variation in room setup. I don't like to dwell on this a whole lot and try to dictate how people do surgery. I stand, I know Justin sits. I know neither one of us understand why either one of us does each one of those. The key is it doesn't matter. The key is, like anything in surgery, it's consistency. You need to get used to your perspective of the back table, of the C-arm, of where the patient is, where you are, and then everything either moves in or moves to the C-arm in the exact same way every time. That, to me, that's the key. It doesn't matter. I'm not trying to talk anybody into standing or sitting or head of the table, foot of the table, but it has to be consistent. What do you think, Justin?
I agree with that too. The main thing is that you can reproduce the image you need every time. And as long as your setup allows you to do that, then you can do it however you want.
Yeah, a couple things that are helpful, and I would say worth considering are, we use thigh tourniquets on all of our cases. We have the leg exposed to mid calf, so I have full access. So that is handy. That definitely makes a difference. Also,
I'll agree with that. So I did the same thing. Yeah.
Yeah, having the heel not off the end of the table because you don't want it hanging over to get pressure, but at the end of the table is pretty helpful. You don't want, if you're like I am, where I move the mini C-arm head to the foot, you don't want the table getting in the way. If you're moving the foot to the C-arm, may not be as big a deal, but there's a few little picky points that make a difference. Do you move the foot to the C-arm, Justin, or is C-arm to the foot?
C-arm to the foot is how I do it too. I just had found it, for me, it's easier that way.
Yeah, for me too. And it just, the foot's always in the same position. I don't have to bend the knee. I don't have to wrestle anything around. So, again, dealer's choice, whether you sit and whether you move the foot to the C-arm or use the big C-arm, which certainly can work. The big C-arm's kind of the same philosophy that I use. Big C-arm, you can just move it in and move it out. In our hospital, you have to have a tech to do that though, so it kind of slows me down and breaks my flow. So I use the mini C-arm and just swing it in and out. But again, it's consistency, and the consistency is basically 3 views. We need to see a good AP. I call that the correction view. So if I can't see the sesamoids, hallux, metatarsal phalangeal joint in their normal simulated weight-bearing position, I have no idea whether I've corrected it. And then obviously we need to see the TMT. We call that the Treace AP, which is basically it's similar to a dorsiflexed AP. We're just trying to get orthogonal to the TMT. And then of course a lateral, which I think is nearly worthless unless you load the foot. I mean, this foot, like we're seeing here, in a completely relaxed position, I'm not sure how much information that really tells you. Where are you on the lateral, Justin?
I agree. So if you're looking for elevatus to see if there's correction there, that especially with the mini C, you're not going to get it hardly. And so the only thing I really use the lateral for, and this may be skipping ahead a little bit, is to make sure I don't have any plantar gapping or any little bit of bone left down at the bottom after I've made my cuts.
Yeah, 100% agree. Because you can get a view orthogonal to the TMT, but that doesn't, with this foot sitting like it is right now in a hyper supinated position, we're not exactly sure where that first ray is in relationship to the rest of the foot, which is where we need to align it to the rest of the foot. So the dorsiflexed AP or the Treace view, essentially we're just trying to get it orthogonal to the TMT. You can't do this just by moving the foot and take one view. You got to do just a couple of seconds of fluoro, and you got to move it a little bit up and a little bit down until you get it perfectly down the joint, and then you know you have the joint. I'm not sure, this is probably not the Treace AP, but the true AP, but the Treace AP, we're trying to get the joint. So this is really describing what we want to see when we get a true AP is, proper not overlap of the metatarsals and not too much separation between the metatarsals. The more you supinate the foot, the more overlap there is, the more pronate. The more you pronate the foot, the more space there is between the metatarsals. So you just have to picture in your mind what we see day in and day out on a weight-bearing AP X-ray, and you try to simulate that. Any tricks on getting a good what I call either a correction view or an AP, Justin?
Yeah, if those metatarsals start to look crowded, sometimes you have those patients with a really narrow foot, and then on a real AP, those metatarsals are crowded. We all sort of know what that looks like. If a lot of your images look like that, then you're definitely supinating that foot. And I think there will be an X-ray view that sort of shows that. And that is probably the most dangerous view, I feel, that you can get in the OR trying to correct the sesamoids, because it gives you a false sense that the sesamoids are reduced when they're not. So that's probably the biggest thing, just making sure that those metatarsals are spaced out well, the toes are going out straight, they're not in that valgus position. And then to make sure you're not pronated, you really are going to look at that lateral cuneiform. If you can sort of see that lateral cuneiform on a good view, then you're too pronated.
Yeah, that's a great point. And it's interesting, I was going to use the exact same word as dangerous. And the danger in getting a supinated view when you're trying to assess your correction is you can make those sesamoids look great if you just keep supinating the foot. And I guarantee you, when that patient comes back to the office and does a weight-bearing view, you're going to be super disappointed. And it's not recurrence, unfortunately, and I'm the first to call myself out when that happens to us. That was 100% me. I didn't get a good view, or I didn't get good correction, and I get a proper view in the office and things look off. And so very important to just know what we're looking for. So this talks a little bit about, changing the perspective. So you can change the sesamoid position dramatically just by supinating and pronating the foot. So we just want to get that good straight on AP. We all know what it looks like. You can see the first and second cuneiform. I really like that assessment, Justin, but you can't really see the third. And now when you look at the pronated view, you see the whole third cuneiform and you barely see the first cuneiform. But we've seen this. We've all done this where we've, supinated the foot to make ourselves feel like we've gotten correction and really haven't. So we really want everybody to be able to recognize that and not get into that situation where they're using foot position on the fluoro to, kind of kid themselves into the fact that they got correction. So dorsiflexion and plantar flexion. So I get called out a lot. People look at my x-rays and they say, well, they look short. And I guarantee if you look at the lateral on 99% of our patients, they're in either neutral or slightly plantar flex position. So yes, they're going to look shorter relative to the second, but they're going to be functioning normal. And it's all about geometry. If you the quickest way to elevate the first or to lengthen the first ray is to elevate it on an AP X-ray. Yeah, that's just the fact.
Yeah,
So
I agree with you there.
How do you assess your dorsal plantar position, Justin? I mean, during a case, walk me through what you're looking at to make sure you're not too dorsal or too plantar, because we can be too plantar sometimes too.
Yeah, and so I'll do what I call the sort of piano key test. And I wish I could sort of see them, but I like to put my hands across my fingers across the dorsal aspect of all the metatarsals and my thumb on the plantar aspect. So I'm sort of grabbing the forefoot, and you can usually feel if that first ray is up in relation to the second and third. Yeah, I mean, it is a bump. And so if I feel that, I know that I am elevated. I know I am. And so I think it's maybe a little bit harder to feel if you're plantar flexed as much. Because some people have big sesamoids and some of them have smaller ones. So that one's a little bit tougher, but I feel it's pretty easy to feel if you're dorsiflexed.
Yep, I 1000% agree. We use a combination of palpation. So dorsal joint of number 1 to 2 through 4. And then we also try to assess plantar with the foot in neutral position. And then x-ray, of course, like the interesting thing is we don't talk about this a lot, but it's a real phenomenon. So if you're elevated, your sesamoids shift proximal. And if you're plantar flexed, they shift distal. Now they're not shifting, obviously, it's just x-ray artifact, but you can see that in the middle and the right pane. And so you can even use the sesamoid. So we're not just hanging our hat on a lateral fluoro. We're using multiple ways to assess whether the first ray is in the proper position. And that's my number 1 recommendation on sagittal plane. You have to palpate and do an AP and do a lateral. All of those have to correlate to be able to assure yourself that you're getting good correction. And again, just back to the lateral x-ray is trying to lie to you every time. So use some kind of a radio lucent plate, load the foot, and try to get a true lateral x-ray. That'll keep you safe in a lot of cases. So,
and I will say, if you do have a big C, that is the best way to get a good lateral, and you have to have that radiolucent plate. I've got my team to make me some plexiglass. They cut it, and I will load the foot if I am using the big C, which is a little bit rare now, but if I am, you can actually load the foot and get a good lateral. But I still find that on the mini, it's still not a true lateral, even if you load the foot, because it's just not a big enough viewing field.
Yeah. So this is kind of the crescendo of the whole discussion right here. So, we get this view intraoperative, look at those sesamoids, they're perfect. We're all high-fiving, I'm ripping my mask off and throwing it on the ground. It's awesome. And then we see the first post-op at 3 weeks or 6 weeks, whenever you get your x-ray, and you're like, oh my gosh, what happened? The sesamoid slipped. Well, no, they're no different than they were. It's just that now the foot is in a normal AP position, and we had this very supinated aspect of the foot. And again, I think the lateral x-ray tries to lie to us all the time, but the AP can certainly lie to us too. So we really have to be, cognizant. Look at the talonavicular joint and the relationship between the TN and the CC. This is a supinated foot. Look at the overlap of the metatarsals. And yes, if I'm just focused on the first ray, that looks fantastic as far as alignment. But when you look at global foot alignment and then the first ray alignment relative to global foot alignment, this is not a good, it's not a good thing at all. You can even see, look at the plate position, Justin, where now the plate is not in a bad position, but much more medial than it looks on the intraoperative view.
Yeah, I agree with you here. And if you know to look for it, then you'll know when you're doing it. But the problem is if you don't really know to look for it, then it's easy just to slip this by, and then you get that post-op and you're like, dadgummit. But now that you really sort of know what to look for that in the OR and be like, hey, whoa, let's make sure that this thing is a good AP, and it'll become obvious after a little bit. You just have a few cases and it'll become pretty obvious.
Well, and the other thing I will say too is, when you look at the flow of a TMT triplane realignment, we should never get to this point and have plates on and have a supinated view that is the only view that looks normal of the first ray. There's so many opportunities, and we talk about and we practice. We live the fact that we get x-rays at every incremental point in the case. And so this could be caught when we're doing the correction. We have the fulcrum and the positioner on. It could be caught when we have the two temporary fixating wires on. It's super easy to fix at that point. We're like, oh, well, we didn't get it quite there. We need a little more rotation, so we dial that in before we have plates on. The worst case scenario is not seeing it until plates are on, and then it becomes a huge hassle. It's a big decision, either take everything down and kind of start over or accept it. But I can tell you, because I've been there, sesamoid position like this on a true AP is a recipe for a unhappy patient. So I think we beat that one to death. So
yeah.
All right. So what can we say about the lateral?
Yeah, I mean, the lateral, we all know sort of what a good lateral looks like. You can sort of see the bottom of that fifth metatarsal. If you're supinated, that you see really that metatarsal moral profile. And if you're really more of a pronated position, then all the metatarsals tend to line up together. Like I said, I don't find the lateral as helpful in the OR, though. I think pre-op, yes, it is very helpful to see that. See if they do have some elevatus. I know I'm going to have to really work to get that where I need it. But in the OR, it's not quite as helpful, except when looking down the joint. And I know we have a few slides on that later.
Yep, absolutely. So, again, it's like anything surgery-wise. I mean, surgery is complicated. It's all three-dimensional. It's a combination of palpation, kind of hand-eye coordination and correlation to what you see on the x-ray.
So that being said, we talk about this a lot at our really advanced programs, at our Centurion events, the effect of the palpation, of the parabola. However, this view, and we'll get there maybe a little bit later on, but what would be the impact of taking this view at least pre-cut? What would you be looking for?
What I would be
Well,
looking for would be our alignment of our cut guide, so our joint seeker. If you're talking pre-op, I mean, I think Justin and I touched on, I mean, we want to know, is it dorsiflexed in a weight-bearing position or plantar flexed relative to the rest of the foot structure? But with a fluoro, with the foot relaxed, I'm not sure it correlates with what we're trying to do. I think we need to get to the point where we're loading the foot. And actually, Justin is the one, and he probably doesn't remember this, but it was many labs ago that we've always done the background and technique together over many years. And he talked about this, plate that he had made, and it was a light bulb for me. Like, that's what we need to be doing. We need to have a plate. We need to load the foot. We need to look at a not a true lateral, but at least a simulated weight-bearing lateral.
yeah, and that was super helpful for me, even like you said, visually, because I mean, I'll load the foot and this is how they're going to be standing on this thing, and I'll look at it and I'm like, man, if something's off, you can usually see it even there. You'll see that first ray up if you load the foot.
Yeah.
So if you don't have any type of thing like that, some people will use the back of a lid from one of the back trays, but some of those are metal. So you just work through that in your head of getting some type of surface that you can put it. It needs to be pretty rigid. Some of them are too flexible and it doesn't work. So get one that's pretty rigid and load the foot. It helps a lot.
It needs to be a cutting board, one of those
There you
plastic
go.
cutting boards. That's what it is. I mean,
Yeah.
so Lauren, I mean, this is great discussion, and we need to have open and frank discussion about what we're doing. So you look at that severely pronated foot, the first and second cortices are parallel. So if I'm a new surgeon and I say, you told me to get them parallel, they're parallel. But that's not a realistic situation for, weight-bearing structure. And the elevated one, that's a weight-bearing view. So, we're not talking apples to apples. So I think the best thing we can do is, as we learn and as we go forward, is we have to figure out a way to load the foot to get a good lateral. Now, to look at, Justin brought up the absolutely good points about what we can do with the lateral. You don't want a piece of bone in the bottom. We're going to look for that. We don't want a gap on the bottom of the joint or the top of the joint. We don't want offset, right? We don't want translation, dorsal or plantar. None of that is good biomechanically. So, even though I said it and it's true, I don't get a lateral very often, there are good things that you can learn from a lateral x-ray. I'm not doing any better, am I, Lauren?
Well, there's
still
a
there.
slide later that'll
No,
show
you did great. You did great.
Okay, all right. All right, so this is a good one too. We see this all the time. So is this really elevatus? What do you think, Justin?
Yeah, so it's hard to tell. That first x-ray, when they put their foot down, if I see this, I sort of blow it off, to be honest with you. And I don't know whether they loaded that first ray or not. So that
Yep.
first x-ray, the lateral, I don't feel is as helpful. Now, 6 weeks in, if I see that, it's a problem. I was like, I didn't get the correction I needed. You know what I'm saying?
Yep.
But that first x-ray, I see mine back in 1 week. And when they put that foot down for the first time, a lot of them offload that one. And so a lot of them look like this. So don't get freaked out if this is your first x-ray post-op.
Yeah, so I totally agree. Super interesting. So we quit a long time ago getting our first post-ops at 4 days. We don't even get an x-ray because they're just getting on their foot. So at day 4, we get them in the boot. They start weight bearing. By the 3-week view or the 3-week x-ray, which is our first x-ray, they're still not putting their foot, fully on the ground. So I agree with Justin. I don't put a lot of stock in the lateral x-ray. But by 6 weeks, if you're doing the Lapiplasty post-op, which is weight bearing from day 1 or 2 through the whole recovery protected in a boot. They're weight bearing pretty good, but the interesting thing is, and I'd love to hear Justin's take on this, they still have a hard time with the sesamoid axial. So we'll actually, sometimes at the 6-week, we'll skip the axial and we won't get that until their 9-week view. What